Hello and welcome to Community Pulse, a CAN TV program featuring local leaders and organizations focused on improving health and well-being in the city of Chicago. Community Pulse is presented by the Foxglove Alliance, a public healthcare coalition supported by the Hectone Institute of Medicine in partnership with the Healthcare Council of Chicago, managed by Third Horizon Strategies, and Hectone's Nurses and Humanities. My name is Meghan Phillipp, and I serve as the Executive Director of the Healthcare Council of Chicago, or HC3. And I am thrilled to be here today in the studio with leadership from Montrose Behavioral Health Hospital, located in the Uptown neighborhood of Chicago. I want to give a warm welcome to their Chief Medical Officer, Dr. Joao Busnello. I totally probably butchered it still, even though I just practiced, but welcome, Dr. Busnello.
Thank you. Thank you for having me here, and you did good.
Okay, good. Well, I know that Montrose Behavioral Health has undergone a renaissance recently, opening both a children's facility and most recently the adult facility that you are part of the leadership team for. So could you provide an overview of how this newly restored project came to be?
Sure. So the mental health hospital has been in the Uptown community for decades. We are at the site of Lakeshore Hospital, an old standalone psychiatric facility that has been in Chicago more than I have been. I happen to be educated at Lakeshore Hospital. That is a hospital that served as a training site for several universities. I did my residency at the University of Chicago, seeing patients at old Chicago Lakeshore Hospital, and it eventually closed in the beginning of COVID in 2020, and it went through a transition. The hospital is known by serving the community and taking all kinds of patients. It really was a wealth of clinical psychiatry, to the point that, I mean, the universities and the top programs in the city were sending their trainees there to learn psychiatry where it was at. So that sense of being site of great importance for mental health in the community was always there. The hospital went through a transition. So in 2020, it was sold from the previous group to a company that we work for named Acadia. And as a hospital that was in the community for very long and served underserved population, it was in bad need of repair. So at that point, when the hospital was sold, they had two buildings, one catering for child and adolescent, which was a newer one and the easier one to reopen. And that building was reopened by Acadia in 2022. We started in June, so we're 2 years old now. The old building where we housed 100 beds for acute inpatient adults needed an extensive redo. And it was a major renovation. Many of the problems that the old structure had, Acadia addressed them. And we opened a brand new building on January 2nd this year, 2024. And we hope to have all the previous 101 beds opening. Right now we have 1 out of 3 patient floors fully functioning. We just reopened the second one. And by 2025, we hope to have the entire hospital operating again with services that were not provided before. We aim to have an ECT suite, treat for patients with refractory mental health disorders, and be a full standalone adult psychiatric health facility, along with 60 beds we already have in child, and those open in 2022.
Amazing. So can you share a little bit about how your team, you mentioned that right now you're still opening the other aspects of the adult facility, and you are continuing to expand the services. So tell us more about how you aim to expand not only the capacity within the 4 walls, but also how you're thinking about outreach to community.
That's a good question. So the outreach for the community, I think that a hospital having been there for literally decades and being well known in the community, I mean, there is a referral source. I'm using the right word. I don't think it's a referral source, but there is a need in the community, and it's a pretty big community. And one thing that many times lay people are not aware of is there is a huge public health need for mental health. So we just happen to be the hospital in that community, and naturally, I think the Uptown community, the North neighborhoods in Chicago, will have Montrose as their place to go to. We've learned a lot from the experience of the previous companies and the previous providers that were on the site that today Montrose stands. So one way to attract this community and serve their needs for mental health, I believe, are developing lines of excellency. So when I first started, and with the mentality that our leadership wanted to bring forth, Patrick, that unfortunately is not with us here today, but is doing well, and one of the reasons is because he's leading this effort in the field, is that we should specialize in some things and do things that haven't been done for standalone behavioral health facilities. For you to have an idea, the bulk of the need in the United States today is addressed by private standalone psychiatric facilities. I'm talking about acute care, those individuals in crisis that need to be hospitalized for acute management for a relatively short period of time. What these hospitals in Chicago, which have several, did not have, and Montrose comes in as a first, is the line that I spoke just a minute about, ECT treatment. So refractory mood disorders in need of ECT had to be treated at academic centers, medical surgical hospitals, but big facilities that had comprehensive health care, not only behavioral health, and that only have a limited space to dedicate to that. So Montrose is going to be a first on that. I think being well known for behavioral mental health in acute care of mood disorders in particular will create that as a center. And people will be referred not only because we're close in proximity, but also due to the reason that there is a defined line of work, that stuff, that there is a need in the community that spans the populations that we serve in the Uptown area and the broader Chicago area, and that we can be a reference for. I think it will bring back what I had when I stepped in that hospital over 15 years ago as a person who had just moved into Chicago. Academic institutions will first see the need. I mean, because if you're providing those services and they have quality, they will bring their students. And hospitals naturally serve as a site of education. I mean, I'm still learning. I mean, you learn every day, and that's the gratifying part of the job. I mean, you learn as teams. And so catering to education institutions, seeing those lines of excellency that we are trying to develop, I think that's how we're going to, sorry for the long-winded answer, but that's how I think that the community and people in general are going to gravitate back towards the hospitals in the Uptown area, and we want Montrose to be the one.
No, I think that's absolutely right. And I think what you described earlier is that there was a facility and that left an absence, that left a void. And to your point, mental health is a critical issue for treatment. I think what you just described also really shows that Montrose is zeroing in on this very specific, I don't want to say specialty because it's not specialty care, but it is. It's your specialty. It's going to be your area of focus and expertise. You're building a team and building out the muscle of really being able to holistically treat people that have experienced some sort of crisis or have a mental issue. So I think that it's just going to be incredible to see. So how does Montrose Behavioral Health Hospital approach treatment for co-occurring disorders, and what programming is going to make you guys uniquely effective in treating those simultaneous mental health concerns?
Yeah, within the hospitals, I mentioned, speaking for the adult side, which I oversee more closely, but psychiatry in general is one of the largest spending, I think, specialties in medicine. It's my favorite, that's why I chose it. So, but acute behavioral health, just this one small part within psychiatry, what we do, having patients with severe mental illnesses in a moment of crisis, needing acute treatment. I mean, they're being hospitalized for their behavioral health issues that are peaking by the time we see them. Even in this small area within the broad field of psychiatry, there are different diagnoses, there are different cases, and there are different approaches. As we are small, I mean, we started with one unit. So we would have programming, because patients are doing activities when they are in the hospital, and that's something that many times the lay public does not understand what happens inside an acute psychiatric care facility, what happens right after they were admitted, what happens right after the crisis. But they come in for different reasons. In an acute behavioral health setting, we have three major ones. So one is substance use. People come in for detoxification from, now we see the opioid crisis, so that's the one that's most known to the broad public, but alcohol is still the number one reason for people coming in for substance use. Those individuals are in need of detoxification and follow-up treatment. The other part of this trio would be individuals with depression, with mood disorders, and risk of harm to self, recent suicide attempts, crisis within mood disorders. And the third one is psychosis. Individuals that are affected by schizophrenia or severe cases of bipolar disorder, or sometimes drug intoxications that led to psychosis. This is not a group of individuals that you'll put in the same room and will be able to address their needs. Their needs, even from a psychotherapy standpoint, from the talk therapy standpoint, are quite different. So we have to treat them with different specialists. So as the hospital grows, we start dividing it within those areas. Right now, we have acute units treating psychosis and mood disorders. We will be having a unit pretty soon that will deal exclusively with substance use disorders, and some things that we want to specialize in. Some hospitals go in that direction. Behavioral health need of women. It's particularly sensitive because in a moment of crisis, it's delicate to host patients of both sexes in the same unit. So many hospitals, and we agree with that, feel that unit dedicated exclusively to women to provide them a sense of safety. They are needed, and the treatment, the experience, if you will, of that moment of crisis is better if they're able to be addressed in a unit that is dedicated to problems with for women. We talk about diversity today, so it's a little more delicate because we're not as black and white as in the past. You talk about units for men and units for women. Transgender individuals too. That would apply for other people. But the way we're going to segment or divide units within the hospital would follow a plan like that.
Yeah, absolutely. As we zoom out and look at challenges that are surfacing, you mentioned the opioid crisis and alcoholism and lots of things that you treat along the spectrum. So what are some of the most pressing issues, including some of those, and what are you seeing from the referrals? So you described sometimes what has happened is they have gone to the emergency room at their local hospital, and then they're referred to you because of the extreme crisis or experience that they're in, that they need this very specialized service. So what are you seeing as a broader behavioral health trends and the things that you guys are trying to really hone in and support and treat and address?
Okay. I'll give two answers to the same question. We ask, if you talk specifically about me, and I'm a creature that, I'm a psychiatrist dedicated for acute behavioral health. My habitat is the psychiatric hospital, the behavioral health acute inpatient facility. And the truth to that question, and I'm asked, and it's an answer I've given before, is I don't see a trend. I've got this question asked to me during the COVID years. So how did it affect mental health? And what I saw from where I stood is that the hospital was full before, during, and after. So psychiatric emergencies, they are a constant need in the society. But of course, there are trends. In my line of work, those areas, substance use, the units remain full. Problems with depression, problems with psychosis, they did not go away. They were there. There was a huge need. I was in the front lines of that. I did not work remotely. I was in the hospital every day during the COVID crisis, as I've been before and as I am now. So that's from my individual perspective. But some trends are undeniably happening, and we see them on TV, we see them on the media, and there are some things that have been spoken about and that we've revisited the way we care for those. One of them is trauma, PTSD. And I think that if we look into a very short period of time, let's say the last 10 years, the way in which not only us in psychiatry, and I think we can take some of the credit as behavioral health workers, not only the psychiatrists, but people in general, portray that to society and engage society in it, has really changed the debate. One of the things that we are mandated by the CMS, I mean, we don't like to be mandated, but one of the things that they request we do as much as possible, and for you to have an idea, the government asks us to document in our first interviews with patients when they get admitted to the hospital that we made questions to them about trauma. Have you ever been a victim of trauma? Mm-hmm. And it goes in all the ways, emotional, physical, sexual. So that alone shows that we've learned to talk about those subjects that only 10 years ago would be very difficult, and we wouldn't be taught well how to approach them. But we do that now, I would say, more often than we did in the past. And it's a good thing, because one of the problems with trauma is unidentified trauma. Unidentified was basically just a word we would use for not asking for it. We know for a fact people do not volunteer to you the worst experiences they had in their lives. And for psychiatry and for behavioral health workers, I mean, those bad experiences many times have an impact on the situation we are seeing right there and then, and should be asked, addressed, and recognized. That alone will help. That alone, I think, is therapeutic. But many times, I mean, they have lingering problems of trauma that can be addressed, and as they move on from the hospital, we want to give follow-up for that type of care.
Yeah.
It changes. I mean, we know that results for addressing that trauma is associated to several other mental illness, be it substance use, depression, anxiety, and knowing is the first thing. I mean, talking about it, and some of those conditions can be treated with a great degree of success. So that change, that trend that I've seen and I lived in the last 10 years, I think is very real and has been very positive.
Yeah, I mean, you took us right there. I just want to point out that June is PTSD Awareness Month, and that was part of what we wanted to cover. So I'm really grateful that you were able to explain just how it's manifesting in the patient populations that you're serving and how you are thinking about it as a critical piece to what is manifesting. And as you think about that, I want to just zoom out a little bit on the trend line of just, you know, specific to Chicago. You pointed out that we are starting to be able to ask the right questions, and how do we screen for things like that? So being able to ask, have you experienced something? You know, how are clinicians being trained to do that in ways that are ethically, culturally responsive to the types of patients that they're interfacing with, and building that trust to be able to say that truth and be able to unpack and start to move on towards treatment and addressing those issues?
Yeah, I don't think we're prepared from home as human beings to address those questions. I think that the reason why they've been hard and took so long for us to get to the point that we are in right now, where people are talking about it more openly, seeing the problem in the dimension it really has, is because we learned and we changed behaviors, not only individually, but collectively. So the question is, how you teach someone to talk about trauma is very valid. Inside the hospital is something we live in every day. I mean, I saw 2 new patients today. I had to ask these questions to both of them, and we repeated. So how do you ask them? And experience helps. I've been doing that so often that it's been a long time since I've been taught how to ask those. But if I had to teach, and if I had to teach the public who's watching us right now, one of the things about trauma and talking about trauma and therapeutic healing, psychotherapeutic healing, the things that comes first, setting, okay, where you talk about it. So the patient has to develop at least some degree of trust and comfort to talk about that. As I said before, this is not information that is spontaneously volunteered by anyone. Some people do talk about it and bring it up without asking, which is good, but most of the time trauma is hidden and still is. The sense of trust is developing inside the hospital. So having clear environment, sometimes being on a setting individually, people are still embarrassed to talk about terrible things that happen to them. And it's not the first thing you ask during an interview. Mm-hmm. You have to instill a sense that you're trying to learn the person's story, not only the things that brought them to the hospital today, but that there's context also to where they come from. And we mentioned open a hospital for children, and trauma can start very early on in life. Mm-hmm. I would say that among the reasons that bring children to have an acute behavioral health crisis, some trauma that is happening comes right at the top. If we have problems asking adults questions about trauma and having them tell you what they went through, you can imagine how it is for a child. So it manifests extremely different, but it's a problem that has the same name across the lifespan. So it's, I think, more straightforward in the setting and doing several interviews for me interviewing adult patients. But remember, the same question you asked me about how to elicit trauma might have a very different approach depending what the individual you're talking to, the individual's age, gender, sexual inclination, or however you're going to name it. But it is a very individualized type of approach. Mm-hmm. So yeah, some of it can be taught. Experience will help a lot, and we're still learning. I mean, I think we learned a lot in the recent past, and there's still a whole lot more to learn, to work in, and to teach.
Are there any specific initiatives or programs that the hospital has to either raise awareness or educate the public, or just in the line of services, how are you thinking about that pipeline of like, this isn't something that's going away, but this is going to continue to be an issue, and continuing to bolster your services so you're able to, I don't want to say hardline, but almost like get to the people admitting all the things so you can start to get to them to the treatment side, Mm-hmm. What are the types of things that people can, even just for people in our public eye to really understand about where you see it in your family and your friends and your coworkers? Mm-hmm.
Yeah, we are not advertising specific lines of treatment for trauma to the general public now. I mean, there's a big trend for our line of work, standalone psychiatric facilities and behavioral health facilities in general, to provide trauma-informed care. So being here, so thank you for this space. Thank you for being able to talk and reach an audience that I'm never be able to reach when I'm sitting at my desk or talking to a patient inside the psychiatric unit. So there is this goal of educating the general public. This is one of the efforts. Being here, we want to talk, we want to educate. We want to let people out there know that there's something that can be done and that you can get very good care for conditions like this. Within the hospital, so there's something very active. The movement I talked about, units have to provide trauma-informed care. So they might say this is an umbrella term, but it has a very specific meaning for us. Number one in it, trauma-informed care is educating our frontline staff. Because these conversations, were hard to have for a reason, and many people were not very knowledgeable about it. Mm-hmm. So us being on the front lines, I think we have to be shouting from the rooftops. And that means that, first of all, we have to educate our house, we have to educate our staff, we have to educate everybody. So in behavioral health facilities, it's funny, but we literally do educate people from the kitchen staff, the cleaning staff. Everybody has some training on behavioral health, on trauma, and the frontline staff more often. There's continuous education. Sometimes even people coming to the work, they don't know that very simple things that might come naturally to you or are meaningless not meaningless, but I mean that you are not aware of, can be hurtful or seen different by other individuals.
Yeah.
This sense of perception of being in an acute care environment and that you being in it has an impact on patients and people around you, we try to instill that, the sense of awareness, how you're relating to others, even the ones that have thought disorders, frank psychosis, and are disorganized, that your behaviors and your demeanor can have an impact and be healing, be therapeutic. So those are things that we teach in-house, and we teach the whole staff on a daily basis, and then formally with courses. I mean, there are several things that are done not only in our facility, and I was telling you about how big the need is. For you to have an idea, we belong to a corporation that has over 150 hospitals across the United States. So we are a small part of that, and this need, this education, applies across all hospitals in our institution and in the whole of psychiatry. So there are things being done in-house for that too.
Yeah. I want to give you one last question, and it'll have to be quick because I know we're running out of time, but would love to just kind of get your future of behavioral health, what's evolving, what do you hope to see in the next 5 to 10 years for Montrose Behavioral Health?
So Montrose, I mean, we are very young, we are new, so I want our name to be known as a place for healing and of excellence. And it's a lot of work. I mean, I think we've accomplished a lot in 2 years. 2 years ago, it was myself and one more doctor, Dr. Nichols, caring for a whole hospital that had 10 beds. So, I mean, we could do that within 2 doctors. Right now, we hit the mark of 120, and will be 160 just for the inpatient care within 2 years. So we are at the point that we have to establish the things I mentioned before. I think our lines of care, be known for things that we are excellent in, and that this is a hospital that stands out. What will happen? I mean, more work is going to occur. We just opened an outpatient area, so we are serving outpatients too now with programs that we call intensive outpatient. Partial hospitalization programs will follow, and I think at one point we'll also be providing individual outpatient care to add to the 160 beds. The ECT line that I said before is something that has not been done in standalone psychiatric facilities in Chicago, where we don't have right now, and Montrose will offer. So I think for that program of treating the toughest mood disorders, people who struggle with depression and had it severe and for a long time, we want to help that population too. And of course, our aspirations is to educate not only the public in general, I mean, using your forum and being part of the debate of mental health, keeping it alive, but really doing formal education. We have our doors open to academic institutions. It would be great to have resident students. I mean, we have a program that's already bringing students to the hospital, and we've been doing teaching, but academic affiliations are at the heart of any hospital, and that's the future where Montrose, myself, would like to go into.
Wonderful. Well, thank you for all of your work in leading this new effort and this renewed sense for the Uptown neighborhood. So if you or a loved one is in need of services, I encourage you to check out Montrose Behavioral Health's website, montrosebehavioral.com. And of course, if you're experiencing any suicidal ideations or other traumatic thoughts and need assistance, 988 is where you go immediately. I want to thank our CAN TV nonprofit services team for their support in today's program. My name is Meghan Phillipp, and it's been a pleasure to be with you on Community Pulse, which airs on CAN TV channel 21 and is also available on cantv.org. Thank you again, Dr. Busnello, and you all out there in Chicago, stay well.